We're going to talk a little bit about delegation in nursing, and this is one of the more difficult things to master for new graduate nurses. It is simply something that you guys do not get a whole lot of time to practice because when in the hierarchy of things in the clinical setting, it's rare that you're given the opportunity to actually be considered almost a real nurse to be able to delegate. And then we have clinical agencies that very frequently let nursing schools know, we just wish that you could get your nurses when they graduate, nursing students when they graduate, to be better able and more confident in delegation. And I have actually asked some facility representatives while I've been in this job, how would you want us to have them do that? Because there doesn't seem to be the openness to do that. So there's a lot of opportunities for improving this process in terms of your readiness to be able to delegate effectively. Many of you may have worked as a nursing assistant where you were delegated to, so you know what you would prefer if someone was going to delegate to you a method or a process that would maybe be most likely to elicit your cooperation to get a task done. And we're going to review a lot of delegation options and ways that we do that best at some point in the course. So we'll be doing a lot of examples and situational things to practice some of that. And we may even be working on doing something more robust than that in terms of a simulation in the program for more of that. So why do we delegate? Delegation is a fundamental aspect of a nurse's role. Florence Nightingale viewed delegation as a critical skill. And as we just mentioned, there's lots of issues with being confident or knowledgeable in not only being able to verbalize and actually delegate somebody to do a task, but being able to know in what situation is it best to delegate certain tasks to whom. Your textbook has a lot of definitions, accountability, assignment, authority, client care activities, the term to delegate or delegation, what tasks are considered nursing activities, what is the scope of practice, what is a CNA 1 versus a CNA 2 in terms of unlicensed assistive personnel. Because on top of everything else, we have more than one level of personnel in terms of unlicensed assistive personnel. And sometimes we have test questions as you go along in different courses where you're given examples of what to delegate to a 1 versus a 2. And I promise you, when you start reviewing, even though many of you have been a CNA 1 and a CNA 2 in North Carolina, if you go and actually look at the task list, every time I teach this course, there are people that are in one category or another, and they tell me that they have absolutely no idea that they were able to do certain tasks that are on those task lists. So we will spend some time looking at that, so you're making sure you're not sending somebody to do something they're not, but in terms of being effective in delegation, that you are optimizing what you need to do to get the job done with people who are capable and certified to be able to do it. And in terms of definitions of supervision, just because we delegate, we have to supervise the task as well. So in 2005, the National Councils for State Boards of Nursing came out with roles of licensed nurses and assistive personnel in delegation guidelines. And over time, different entities have added to this. They had a model for delegation decision making, assess the situation, plan for how it's going to be done, how to communicate it effectively, how to also go back and surveil the task and supervise it if you need to do something with somebody, with two people doing it. But definitely evaluate their performance at the task and provide feedback. Now, many of you have been in the workplace, both as a student and as a worker in healthcare, and we kind of take for granted that all these steps are taking place, but the weakest one is frequently either helping to supervise a task or to go back and evaluate it if it actually was even done correctly or done at all. So when you're trying to make a decision about delegating nursing tasks, you want to look at, is there potential for harm? So are you going to give somebody the task of doing a task with somebody that's high-risk patient for an aide to do it? They're something tricky about their physical condition that makes them risky. Their vital signs are kind of messed up. They're not that stable. They're fresh post-op. Certainly people can do vital signs, but are we going to really give them some of these type of tasks that we know they can do in the midst of some of those situations? You have to decide, is there potential for harm? And if not, maybe that's the task that you want to do for yourself. But also be thinking about maybe you work in the ICU all the time and you have a tech all the time. Just because everybody's a little more riskier than, what level of tasks do you have people do that are regular tasks that are required for those positions, even though you're dealing with a patient population that's a little bit more high risk. You also have to think about what's the complexity of task. Maybe a person is able to do wet to dry dressings, okay? But maybe this person has skin lesions on all four extremities and they're heavy and they're not very participative. Can you really just go, oh, well, go do his wound care dressings and they're going to be in there for 2 hours doing them and they can barely get it done safely? As an example, how hard is the task in that situation? Looking at problem solving and innovation are required. So, who do you delegate to? Will it really work? Thinking outside the box on how you can get some tasks done is important all the time. And then the other piece that you have to be concerned about is unpredictability of the outcome. If this is, say, a new trach patient who's not had a lot of suctioning just yet, that might have some bleeding potential, there is some potential for harm, but there's also some unpredictability if you send somebody to do trach care on somebody brand new. And then the level of patient interaction is an important factor to consider too. There are 5 rights of delegation. The right task, meaning that they, are capable to do that. The right circumstance, is it the right person? Maybe they're CNA 1, but they're brand new. They've never done this task. But there's somebody else who's much more seasoned that could go with them and be really the point person. Are you giving the right direction and communication? And are you really supervising the situation correctly and evaluating it after the fact? What is an unlicensed assisted person's role in delegation? They need to be prepared to receive delegation. And they should already know the usual. If on a unit, finger sticks, glucometers are always done by aides, You shouldn't be having to tell an aide to go get a finger stick. They should know when they're due. They should be doing them because that's part of a normal process that's already delegated to them by their job duty. They need to participate in communication in that informal exchange. That doesn't mean they walk off halfway in the middle of it because they're annoyed or they're busy and they're not listening. They need to be able to accept the delegated task. If they are unsure about some process, they have to be able to have an open communication where they can seek clarification from you as the person doing the delegation. And they need to request additional training or supervision if that's needed. They need to confirm the expectations in terms of what are we trying to accomplish with the task that I'm doing. And if there's any nuances of timing, of it needs to be done before or after a bath, or before or after they eat, or before or after a test, or, just double checking optimal things that they can ask about to make sure they're doing it the best they can. Even though a person delegates, they are still responsible. That you can delegate, but you can't really totally give away all accountability to somebody because you delegated a task to them. You're still responsible for follow-up and evaluation, interventions, corrective actions if needed. The person that's delegated to, they're responsible for their own acts. They're responsible for accepting delegation. They should be doing what they can do. They need to be reporting back to you about things that they've done when they've done it. They need to be accomplishing the tasks that they're asked to do. They need to be asked for assistance or training if needing, and again, requesting clarification at any point in the process for the task. There are 3 organizational principles of delegation. There are organizational legal guidelines and policies. So even though a person got a CNA 2 and they're able to hook up tube feedings and prepare a set of tube feedings for a client that's on them, you may have an organization that had some issue with an aide doing tube feedings in the past, and so their policies don't allow for that. So while you might be used to that in one setting that does allow for that, you need to make yourself very knowledgeable as part of your orientation process as to what are the policies and legal guidelines about this, and what is this organization allowing individuals to do or not do. Other principles: patient safety and accountability. How confident do you feel that the person that you're delegating to can be safe with this situation, and how then that ensures your accountability because it's a good decision to allow someone to do it while allowing you time to take care of other patient needs. And then there has to be knowledge and education about the best methods for delegating, appropriate times to delegate, and so hopefully some of this content will help you understand those principles. The information exchange is just here. This might include all of the components of what you would want to ensure is being communicated. Why is the patient getting this task done? You're going to delegate it. You want to explain the why of that also. You want to make sure that it's accurate and timely and meaningful. A good way to do this is to really ask for the contribution from the assistive personnel, but also, all those other communication things we've already talked about. How do you speak with someone respectfully and take in their ideas about best ways to do it? Maybe they were here 2 days ago and they help with it and they know the patient situation better than you do. And making sure that, it is treating somebody with respect in the communication, In making sure that the information in the delegation is mutually understood. It's important with a lot of people to have them repeat back what it is, or repeat it again yourself if you don't ask them to kind of tell me what I told you to do. Let's go over it one more time, and you make sure you tell me if you have any questions about it. That way, you're always ensuring there's not mishaps related to caregiver communication. And then the physical, intellectual, and emotional presence in the conversation. You don't know how stressed out your coworker is until you ask. You don't know how they're physically feeling that day, or if they're mentally understanding you, unless you really get at those things in the conversation. You're going to have some quizzes and things to practice prioritization and delegation in the course, and those will pop up at times for you to just practice. But nurses use ongoing assessment to prioritize patient needs. And unlicensed assistive personnel don't know what you know, and you don't always know what they know unless you talk about those kind of things. This needs to come before that because of this other thing we're doing this afternoon, is a key point that might need to be shared with an aide to make sure some task is being attended to timely, or in the correct manner. So prioritization is a non-sequential decision-making process that is ongoing. So another thing to think about is things change in patients all day long. So you can delegate, and it's safe at one time, but later in the day when they come back from a procedure, it might not still be safe. So recognizing that things change at intervals throughout a shift that need to be rethought through again. And then I would like you to consider, can nurses delegate to other disciplines? Technically, we have no authority or direct supervision over other disciplines, but we can utilize their expertise and should call on them if tasks that come up are in their wheelhouse versus ours. And we should be, continuing to follow up with them and make sure that they're coming to handle a situation if needed too. So that's one that's a little trickier, and we'll delve more into practice with. This is just a prioritization hierarchy. Is there imminent clinical concerns? Is the patient stable? Is there, something risky or unsafe? Is this a high uncertainty activity? Might need to handle those things quicker, right? Is this a significant core clinical caregiving thing like managing pain that needs to be addressed before it gets out of control? Maybe it's relationship management. You've got some family member that's really upset and angry and is going to escalate more and more if you don't go get in there quickly to handle it. So, thinking about, when do I document? Documenting all along is great, but if you have some of these things higher up on the hierarchy happening, sometimes documentation is brief and then you come back and add to it later. Might be a good suggestion. And then helping others and support, patient support, like, okay, I'm caught up. Let me go see if other teammates need help. Maybe there's other things that need to be done on the unit that now I'm caught up, I can go work on. And then last of all, which I don't always agree with this in terms of personal breaks and social interactions, maybe, but personal breaks is kind of important too, to you being able to continue to really use good knowledge and skills at these higher things on the hierarchy. So I think that newer literature than what our textbook had will be, as time goes on, more understanding of how self-renewal probably comes before cleaning and preparing supplies, for example, because you've got to stay, strong throughout the whole time frame that you're there. These are some of the common barriers to delegation. Status, the patient, maybe the workloads for either the nurse or the assistive personnel is maybe getting in the way of where you even have time to delegate something or even see the person to delegate, or their workload's so busy you don't feel like they're going to be accepting of it, and vice versa on your end. Risk to the patient and the organization, sometimes it's not always a risky patient in a sense, but you just know that it's the kind of thing that a certain patient is going to expect you to do or follow through with because they want it right now. You don't want to have complaints. You have a lot of times people will say, I have a lack of time to delegate. And that's somewhat of an oxymoron, because the whole idea is you need to delegate to allow yourself to have some additional time to handle some tasks. Lack of trust in your personnel. And I'll give you a good example. One time I had a CNA that was a CNA 1, and they'd been a CNA 1 for 2 years. And one of the tasks on the CNA workload in North Carolina is to give general enemas. Well, I really didn't have time to go work with the patient for a long period of time at that point in the day. And the doctor really wanted this patient to go ahead and get an enema that morning because they had to go out later to be discharged to go to a nursing facility. And so I asked the CNA if she could do that. And her immediate response was, oh, that's not on the CNA 1 list. And I said, yeah, it is. And, you're hired to do that. Are you telling me you don't know how? Or you've not done it? And she said, no, I've not done it before. And so what I did at that point, I could have rushed in there and gone and done it. But I thought, no, it's more important for me to show her how to do it and let her participate in that, so that she is kind of technically signed off on doing that, so that we don't have this same issue in the future. Let her optimally be successful in her work and what's expected of her as well. Sometimes people don't have high self-esteem. When you first come out of nursing school, you're like timid and you're kind of like, I don't really know how to tell somebody to do something. I barely out for my instructor telling me what to do. And so it takes practice. You're not going to get self-esteem at it if you don't just do it. So be thinking about how you're going to, think through your own confidence and self-esteem level, and be thinking, what are my strategies going to be? Sometimes it's a lack of understanding delegation, and delegate the wrong things, or you're just not certain. So part of our course will be to kind of get into the understanding of that much better here. And then leadership style and communication skills that we're already discussing previously. And then there's fear of retribution. And so maybe I ask me to do something, they don't do it. It's now the end of the shift and it's still not being done, and I have to then go back and do it again. So I'm kind of being punished. Or maybe it's, I delegated this, they didn't do it well on purpose, or because they weren't capable, and now it's on me, And sometimes it's just, I gave this person and asked them to do something, held them to do it, and now for the next 3 weeks, they're going to be uncivil to me in the workplace. These are types of delegators. There is the nurse who doesn't delegate. Instead, she does it all alone, or he does it all alone. This person is often stressed, hurried, under pressure, and they're likely to miss details and have some stuff undone because they just can't get to everything. And sometimes it actually causes resentment with the personnel because they feel like you don't trust me enough to do something. And so that's never a good work situation. The rationalizer is somebody who they feel the need to rationalize, explain everything about why they're delegating it. Um, they don't want to be looked at like they're being lazy. And they sort of may lack self-confidence about the process, fear some retribution. And sometimes that person, by over-explaining it, makes for more conflict between the two positions also. The pal wants to please everybody. They're concerned about seeing as pushy or bossy. This can kind of cause mistrust or lack of respect because they look at you just like a buddy and at the same level, and may or may not really want to do what you're doing anyway. So you can be too much of the pal and not the supervising nurse, and that can create problems. The shining example believes that if they're a good example, others will pick up their skills through observation. Sometimes that can cause confusion and distrust due to lack of communication. In other words, watch me do everything instead of me communicate to you effectively. And sometimes it can create problems with poor patient care, just by trying to be a good example instead of actually taking and side by side teaching somebody and supervising them. And then there's the watchdog, which is a definite one that's hard to deal with because they embrace their accountability as a nurse to the point of repeatedly and intrusively checking the work of the aide. They may lead a lot to resentment of your personnel. Here's some solutions to delegation barriers. There's got to be mutual respect. You can't demand respect, you have to earn it. Feedback, positive and negative. It's easy to tell somebody, thank you, you saved my life helping me do these tasks today. It's a whole other thing when you have to go back like, next time when you do this, let me give you a tip. Here's what really needs to take place, or here's how you can do this easier, or whatever it is about it that you have got to give some constructive feedback about. And then supervision, how much do you need? You need to go back and check and see if things are being done that you've asked to be done. And again, communication is clear and ongoing. So it's not just once, it's like communicate throughout the shift with your assistive personnel. You really need to know your scope of practice. Again, some of these may be agency specific too. The Practice Act defines activities that only nurses can do in North Carolina. The Board of Nursing in North Carolina defines Nurse Aid 2 activities. And currently, the Nurse Aid Registry for North Carolina has the definitions for the CNA 1. However, I have heard that in the near future, likely this year perhaps, the NA1 may be coming out of the registry and also going under the Board of Nursing. So I have not seen the actual details of when that may happen, but I have heard that that is in process of coming to being. So we'll see how that works in the future. In the meantime, make sure that you really look at all of the categories, because you're going to get test questions and you're going to need to know these things when you go into practice and be delegating. You've got to know what an NA1 and an NA2 in this state can do. The other issue to know is, under law, nurses are not permitted to passively observe substandard care. So if you have some standard things that just aren't happening, and the aide is supposed to be doing those tasks, whether you've overtly delegated them or not, but they just aren't giving a bath, they're not offering one, they're not feeding a patient, they're not attending to something safely. You can't just let that go. You have to take action to remedy that kind of care situation. And And safety and ethical concerns must be reported to management. So it's not like, oh, I shouldn't report that, I don't want to get somebody in trouble. You've got to report those things. So just know your license depends on you being ethical and report things that are necessary. There are issues related to cost containment to be aware of, budget constraints versus safe staffing, which we'll talk about in another chapter later on. And inadequate staffing is not a legal defense for inappropriate delegation. So just to say that something is not, staffing did something and it created a situation, it's not a legal defense, because you should never be delegating something to somebody who is not credentialed to do it. When an assistive personnel accepts a task, then they should shoulder some of the responsibility, but the nurse is still ultimately held accountable. And, the question is, who would be sued and why? The nurse is legally accountable, so they're more likely to be sued. And a nurse aide's salary is not very high, so likely they don't have liability insurance. So while it's great to name them and they can explain what was going on and be a witness to the situation, they definitely are not usually people that are sued. Usually, if there's negligent care and someone's accountable, the hospital will be sued related to its employees, and nurses may directly be sued as well. The nurse is obligated to answer for their own actions, including how well they supervised a situation. So there are other delegation issues, whether something is direct delegation, like you go to somebody specifically and delegate a task, or indirect because someone's job description says that they do all the vital signs, then they should be doing them. But that doesn't mean that you don't ever watch to see that they're done right, or you don't investigate and look up to see what kind of values they put in, or just evaluate the patient in general. Other issues, of course, are communication failures, which you can imagine, and then not always knowing what to do when you're in doubt about a situation. Use your chain of command. Talk to your supervisor. Talk to your charge nurse. Speak to other nurses on the floor. What would they do in that situation? And get some other ideas that might help you move forward with getting very good at this. It's important as leaders that they should really focus on delegation education to the staff and coach staff in the use of delegation. And again, use things like team steps when there's problems to really use a framework to talk about how this could have been a safety concern, even if it wasn't something that this time ended in a terrible outcome. Here's just a few other issues and trends to be thinking about with more shortages of nurses, there's greater acuity of patients, technological advances, therapies are getting more complex. So the whole healthcare environment is getting more difficult to navigate around these kinds of concerns. So it does have a bearing on what do you delegate. You're kind of concerned that, you're short of nurses and you're only one person, and you need to use your time wisely and effectively, but at the same time you have to really use those 5 rights to make sure that you're being legally sound with how you're doing things.